Is medication-addicted treatment something I see continuing through a person's life? That's a great question. So let me first say, funny, it's interesting we have to call it medication-assisted treatment rather than just treatment. If you get your depression treated, does that specify whether it's medication or therapy or TMS? So it's funny, even in the words, we say, oh, it's medication. Oh, that's like this other thing rather than, if you go in the hospital for treatment of your heart problem, it might be medicine, it might be physical therapy, but they don't say, oh, you're going to get medication. So I'm just pointing that out because addiction specialists, it bothers us. That in this brain disorder, now all of a sudden, oh, medication-assisted treatment. But anyway, and keep in mind, one of the medication-assisted treatments is an opiate blocker. We recommend it's continued as long as the patient and the psychiatrist think that it's in their best interest. Now, if I'm going to give you some money to do a study, this is how I'd answer the question. I'm going to give you some money to do a study. You think I'm going to fund your study for 10 years? No. A year? Maybe. But that's it. So we don't know for sure. I mean, I have clinical experience treating patients for years and years and years. And methadone, anybody know or heard of somebody who's been on methadone and had a life for decades? Okay, so that's a natural experiment in medication-assisted treatment. And we know in studying methadone that people go along and some cultures give people heroin. You know, I mean, that's what they do in Portugal. But the point is, the other piece that I bring to bear that you now have in your mind, is it possible that opiate dependence is a scar? It's possible. And if somebody has a seizure disorder, a scar in their brain, they get a car injury, they have a scar in their brain that makes abnormal discharge and they're going to have a seizure. When do I recommend they go off medicine? I don't. You could, but then you're likely to have a seizure. So it's possible that for some people, medication-assisted treatment may be long-term, but we just don't have the data because 10, 20-year studies is just like, right, it's really hard to do. One other example, treatment-resistant depression. You've had 3 miserable depressions where you've been suicidal. When do I recommend you go off medication? Never. Why not? Because you feel better. Because the research we've done shows that your chances of going for 10 years and not getting morbidly depressed is like 2%. You can play those odds, but I wouldn't recommend it. So there are other brain disorders already where chronic medical treatment is the standard. And no one says, you know, you haven't had a seizure in a year, John, go off your meds. We just don't think of it that way. That's why I'm really passionate about teaching about brain-based problems, because nobody says that. Nobody says to a patient with bipolar, taper off your lithium, you've been doing fine. I'm evaluating right now a professional who has been on lithium for 10 years, doing great. Am I going to recommend? And he was not doing great before. Am I going to recommend he just tapers off because, actually, no, I'm not. That'd be ludicrous. So why do we think about addiction differently? Because our models may not fit with standard neuroscience. Other questions? Great question. So have they changed their brain if they recover from their addictive disorder? Yeah. Yeah, they're making different choices. They're rolling through the world differently. They're avoiding certain things. That's all brain stuff. And if they did that, again, if they did that and they're rocking and having a life and loving and working, go for it, champ. However you got there. I'm not, you know, if it's purple nail polish, keep rolling. But your question had a second part that was more difficult. Oh, placebo. The placebo effect is this. Human beliefs and expectations change brain activity. So do persons' beliefs and expectations change the way they roll through the world? Yes. I hope that someone with an addictive disorder has a belief that if they put that molecule in, they're going to get bad life out. And will that belief change the way they roll through the world? Of course it will. Now, does that live somewhere in here? Yeah, it must. Can I explain it? Not well. So beliefs are powerful. You know, that's what took all the people in Heaven's Gate away, right? Beliefs are powerful. People blow up buildings for beliefs. They're powerful stuff. Great question. We are with TMS where we were back in the day when there's a day once where what we had was Thorazine and imipramine. That's where we are with TMS. And in fact, we still use the same dumb names for medicines we used then. So it's at the infancy 20 years ago, I was working with a psychiatrist in Israel who's kind of farting around with TMS. So technology has a long lifespan. We're just not there yet. But are people talking about it? You bet your boots they are. There's not enough good data. Yeah. Yes, sir. Dysthymia is chronic low mood. Some people have that. They must. I mean, if someone can have chronic high mood and someone can have normal mood, then chronic low mood. The best treatments for chronic low mood are antidepressants and mindfulness-based cognitive therapy. That's my understanding. Same thing as for depression. So it's thought of as a form of chronic low-grade depression, just like you can have pre-diabetes. Yeah. Yes, sir. I love it. See, I hooked your incentive salient system. No, I did. I'm not joking. Interest in learning is part of the incentive salient system. So, I would recommend SAMHSA and SAMHSA's website. Your tax dollars paid for anything you can get written by Nora Volkow, who's like this dominatrix of neuroscience. I mean, she's unbelievable. You can send me an email. I could send you enough information to, but that might clog our server. But some of the government-sponsored websites have tons of information. The video Pleasure Unwoven is pretty good. A lot of what I talked about today is an accretion of like 30 years of obsession. But again, if you wanted to email me, I can feed you books until we both blow off this place. There's a lot of because addiction neuroscience actually captures almost the whole deal. One of my passions about addiction is if you really get addiction, you can kind of understand how this thing works. I think it's a pretty all-encompassing disorder because, like I mentioned, my son, who I love, I think love is basically a good manifestation of the addiction circuitry. But don't quote me. It reminds me of a concept that I hold actually very near, which is the human brain was actually not designed to figure out how the human brain works. Rosencrantz and Guildenstern, there's a quote that we're tied to a language that makes up in obscurity what it lacks in precision, or something like that. So language is going to fall short when describing really complex processes. So it's possible that neither word is right, or that, sometimes it's just hard to get things just right. If you take a writing course and try to describe smells, you're going to have a hell of a time because our language just doesn't wrap around that too well. So, we just got off all fours not too long ago and went from grunts to syllables. So, it wouldn't surprise me that it's hard to find a word that fits your understanding of this complex process precisely. It's a work in progress. What the experiment I showed is more strongly. Because, if you talk to other people, alcohol feels good. For some people, I think it feels real good. And what we know about the brain is, so let's say I take someone with childhood trauma and someone without. Let's say you have it and you don't. If I poke you in the foot, your amygdala is going to light up. But his amygdala is going to light up more. So stimuli can have that's part of individual differences. Part of what makes a Labrador run up and jump on you is his brain gets lit up with people. And if you're an Akita, those stuffy Japanese dogs, like they're going to glance at you. So their brains, the Akita notices you, but he doesn't but the lab is like all over you. So the lab is like the alcoholic, and so that's the way. That's why the naltrexone works when it does, but it doesn't work for everybody. And our understanding of the unique biology of addiction is just still primitive. I'm conscious that some people have been sitting for 76 minutes, 76 minutes. So let me just thank everyone for your rapt attention. I will be here for questions, but for those of you who are patiently gritting your teeth, thank you. And again, I'm here for questions.